would like to welcome you to joint session of World Heart Federation and Great Wall International Congress of Cardiology. Also, I'd like to take this opportunity of inviting all of you to the next World Congress of Cardiology, which is going to be in Dubai in December 2018. You are all familiar with this slide, which is taken by Brunvord and his colleague, which is showing the cardiovascular continuum. And you can see that it all starts with cardiovascular risk factors, manifestation of cardiovascular disease, heart failure, and unfortunately death. The management of heart failure is very important because the number of patients with heart failure is increasing thanks to our colleagues in interventional cardiology and all the advanced successful trials that we have in the management of ischemic heart disease. So more and more people will survive acute coronary syndrome, and eventually they end up having heart failure. Management of heart failure is very expensive. It has been estimated that it costs at least $260 million or 2% of the whole healthcare budget in Sweden. Unfortunately, a small number of patients are on optimal medical management, and the prognosis is bad, and heart failure in cardiology is like oncology in general medicine. The other issue is the question of readmission. Heart failure has one of the highest readmission rate. About 27 to 47% of patients with heart failure, they will be admitted within 3 months after being discharged by you. And about 50% of these readmissions are actually preventable. The most common cause of readmissions are non-compliance with medications, inadequate medications, and poor knowledge of the patients about their health and their cardiac state. If you want to summarize the management outline of heart failure, you see the first step to have the accurate diagnosis, which will be followed by the symptom severity of the limitation, the etiology, comorbidity, therapy, and of course to try to improve the prognosis. An effective program for heart failure management should have a multidisciplinary team approach. It should have a vigilant follow-up. The first follow-up, according to guidelines, should be between 10 to 14 days after being discharged. They should have good discharge planning. They should have access to healthcare. They should be optimal guideline medical treatment. There should have the knowledge and education to flexible diuretic regime. They should have counseling, behavior strategies, and we should eliminate all the barriers to compliance with the list of medications that usually heart failure patients take with them home. If you take, for example, education, which is very important in the management of heart failure, education takes time. For example, you have to give general advice about medications, drug counseling, rest, exercise, vaccination, dietary, fluid intake. For example, if you take beta blocker, you have to spend a lot of time in the clinic talking about beta blocker, how to initiate it, how to up-titrate it, to say that, as a matter of fact, when you start beta blocker for heart failure patients, initially they may feel worse, and later on we see the positive prognostic effect of beta blocker. So disease management program actually is a unique example of how the ideal management program of heart failure should be. Disease management program is defined as multidisciplinary efforts to improve the quality and cost effectiveness of care for select patients with chronic illness. Well, disease management program in heart failure is a multidisciplinary system, meaning that we have physicians, we have heart failure nurses, we have pharmacists, nutritionists, physiotherapists, and psychologists. It is multi-dimensional because it can occur at the hospital clinics. It can be delivered by nurses, and we can even use telemonitoring for the management of heart failure patients at home. It is multifaceted. It can be based in hospital. We should include the discharge planning. We should include the condition and the deterioration of the patients. We should include a situation when a new diagnosis arises. We should have annual review, and we should try to prevent heart failure and readmissions. Well, when I look at heart failure management program, it resembles a football team, and not because my son plays football professionally, but because it really resembles football team. We have main players, we have supporting players. And like a football team, the main players are physicians, heart failure specialists, or cardiologists, and heart failure nurses. We have the goalkeepers, the emergency department, who take care of acute decompensation. And in the middle, we have dietitian, pharmacists, we have home care social workers, we have general practitioners that follow up the patients in their clinics. So, like a football team, we all have a common goal, and sometimes we play with the whole members of the team, but time to time, according to country, according to budget, according to hospital and healthcare system, we play with a smaller team. And we have some reserve players like psychiatrists and pharmacists that time to time come into the football pitch. So the main players are physicians, as I said, either cardiologists with heart failure expertise, or internists with a special interest in heart failure, or GPs. The nurses are also the main players, and they could be ordinary nurses who take care of heart failure patients, or heart failure specialist nurses. The heart failure specialist nurses, the concept was described in literature back to 1983, but the first nurse-led heart failure clinic in Europe was actually started in Sweden in 1990. And later on in 1994, the first accredited educational program for heart failure specialist nurse in Sweden was established. If we compare us physicians to nurses, we as physicians, we can diagnose, we have the access of the cardiovascular status, we can design a management program for heart failure patients, and we can fine-tune the therapy. But unfortunately, in China and in Dubai, we are heavily overworked, and we are not easily accessible or available. On the other hand, our nurses can listen more. They can establish a close rapport with patients. They can ensure compliance. They can be accessible more than physicians. They can perform basic management They can up-titrate your beta blocker and ACE inhibitor or ARB that you prescribe for your patients. They can elicit details and detect early decompensations of patients with heart failure. Going back to football team, after the key players, we have other team members. We have pharmacists, psychologists, physical therapists, palliative care specialists, and software engineer. Pharmacists can be very useful in medication compliance. They can visit your patients when the patient comes for admission or they visit accident emergency. They can talk to them about medication informations and the cost of medications. We can have community pharmacists, we can have hospital pharmacists. In certain countries like Sweden, they have home visit by pharmacists even that we don't have in Dubai. Psychologists, they can help your patients with heart failure if they have inadequate coping, if they are anxious about their disease. They can talk to them about change of behavior, insight in motive and behavior, and training of social skills. The physical therapist is very, very important in the management of heart failure. They can improve functional capacity, quality of life, they can improve symptoms, they can prevent readmission, and they can prolong, hopefully, survival and quality of life. The palliative care provider or advisor, they can help us with the anemia or comorbidities, infection, non-compliance, and in some measurement like inotropes that can improve the situation temporarily. The planning of a good death is as important as a planning of a good life. Because it's an issue that is very difficult to talk to patients about, whether the home is appropriate environment for a good death, is there a need for oxygen therapy, fluid, diuretics therapy, sedation needed, who will regularly assess the patient's condition, advise on the need for a change of treatment. But like a team, we should have a common strategy. We should have the mutual goal setting to decrease the hospital readmission. So this is one of the main strategic targets. We should enhance quality of life. We should decrease the cost of disease management and try to improve the survival. We should all have team spirit, case discussion with input of the whole team. We should have mutual respect for each player. We should know each other's strength and limitation. Not everybody is keeper or left-wing player. And we should consult and refer, because that is the multidisciplinary management of a disease. What is the role of the supporters, like in football, for example? We know these are the 3 studies, and one of them actually was reported in China, that patients who have less family support, they have worse prognosis. Lack of social support predicts early mortality in heart failure patients. Single marital status predicts mortality, which was reported in China in 1997. Social isolation predicts mortality in 2001. 21% of readmissions are related to inadequate social support. We see it in clinical practice, and I'm sure you see it in your daily practice as well. The family member of a patient with heart failure not only help in their transportation, diet, medications, symptom recognition, but also they provide emotional support in coping and if they have depression symptoms. So ladies and gentlemen, to conclude, patients' care in heart failure is like a team approach. like in football team, you should cherish the role of each player, the sponsor, and the coaches. But it's fundamental to recognize the role of the patients at the cornerstone of the management. And thank you very much for your attention.